I'm Dr. Demetrio J. Aguila III. I'm a peripheral nerve surgeon, I'm an ear, nose, and throat surgeon, and I'm also a plastic surgeon. I'm the host and founder of the Direct Care Movement podcast, where we dive into the intricacies of direct care, whether it's direct primary care or direct surgical care. You can find out more about what this movement is and where it's going and where it came from. And we have as our guest today, Dr. Keith Smith, who's the founder of the Surgery Center of Oklahoma and also one of the founders of the Free Market Medical Association. He's a mentor of mine. He's a hero of mine, and he's got all kinds of wisdom to share. So thank you, Keith, for joining us today.
Thanks for having me. I look forward to our chat.
Awesome. I'm looking forward to it also. So why don't we start off by telling us a little bit about yourself so that our audience has a little context?
Sure. Well, I'm an anesthesiologist. I've been in private practice since 1990. Cardiac and pediatric fellowship trained, recruited to Oklahoma City, really to do cardiac anesthesia. So I was in the big hospital cesspool for about 7 years. About 2 years in, I began to see that something was wrong. The hospital was not my friend as a physician. Darn sure not my friend as an anesthesiologist. And then I realized the most astonishing revelation to me was the hospital was not the patient's friend and not their advocate. If anything, just saw them as prey. So I felt like by working there, I was an accomplice, kind of an accessory to a crime, and I didn't want to be part of that. This thing started happening to me that made all of this very clear. Medicare cut physician fees severely in 1992, while simultaneously increasing what they paid hospitals. So at about the same time, the hospitals became very aggressive collecting from patients. I also was part of an anesthesia group that was having increasingly socialistic tendencies where they wanted to share income. So all these things, it's like in Ghostbusters, the streams had crossed. All these things are happening at the same time. And a like-minded partner of mine and I decided we have to get out. So Steve Lantier, my co-founder here at the Surgery Center of Oklahoma, he and I decided we have got to get out of this. And the only way as anesthesiologists we'll ever be able to earn an honest living, look at ourselves in the mirror, act as medical and financial advocates for patients for whom we are caring, was to own and operate our own medical facility. So I'd been on the lookout for a place to build, and along came this place that we could buy that was struggling, going under, and Steve and I actually purchased the place on a hunting trip, which is another story. So we took control of this failing facility, bought the operations, assumed the lease, and we had a simple mission. Patients will always know what they're going to pay us before they arrive, whether they have insurance or not. We'll never take a dime of money from the government. I had stopped filing Medicare claims in early 1993 and just treated Medicare patients charitably. And I've never accepted a dime of money from the government since then, and I'm embarrassed that I did up until that time. And that we were going to provide the highest quality care that was possible to the patients, and that we would work with no surgeons that we would not let operate on us. So that was that's how it kind of got started. That was our founding mission, and it just became wildly successful very, very early. And part of the reason we were successful early is because we were attacked. So you can imagine how what I just described could be a threat to some of the folks in the mainstream. So, hospitals, who were charging for for these procedures, just these outrageous amounts, began to have to answer questions about how can you claim to not make a profit and charge 10 times what I just bought over at Surgery Center of Oklahoma for the same thing, arguably with a better surgeon. So we were attacked viciously by the hospitals, by the insurance carriers, which ironically, none of them, we worked with none of them. They would not let us in network, but they still hated us and they still worked hard to fight us. And then we were attacked by the health department. The state health department was weaponized against us. Looking back, as taxing as that was, as exhausted as I could actually feel right now if I thought through it in detail, that was part of what made us who we are. Those attacks really profiled us as an underdog for the patients. And that was part of what then attracted people to our model and what we were doing. And so everything seemed to backfire when we were attacked. I spent a lot of time at the state capitol, and really, if I went into any more detail, I would just probably physically feel really tired because it was exhausting. But those were part of the building blocks that established our reputation in the community as a patient champion and as an underdog.
Yeah. Well, I loved how you said earlier that you felt like an accomplice in a crime, because I remember when I attended my first Free Market Medical Association conference in 2017 there in Oklahoma City. And I don't remember who, it might have been Jay that got up and was talking about comparing the cost of care, that an employer pays to send somebody for a total hip to a hospital versus what that employer would pay instead with a direct contract with you. And I remember realizing I had done that exact same thing to countless other patients up until that point. And I literally had to fight not to run out of the room and vomit. It was such a powerful, visceral experience for me. And I said, I can't participate in this any longer. I can't continue. Now that I know, prior to that, I could have claimed ignorance, right? But after having been there, all of a sudden I knew. Now I was responsible for that information. And if I continued on that same path, then I was morally culpable for the financial problems that I was causing in those patients.
Yeah, that's interesting. You had that feeling. I was at an AAPS, Association of American Physician and Surgeon meeting, when I met with some physicians who had opted out of Medicare. And I began to realize that I had been the recipient of stolen property. There was no other way for me to look at it. And I don't fault anyone for accepting Medicare patients. And I hope everyone hears that. But for me, to claim that I am some minarchist, minimal government, cut it back as hard as you can, but at the same time, wander the halls of Congress, begging Congress to pay me more in terms of Medicare payments, that just seems so philosophically inconsistent for me. My moment, I think, was right after I had been asked to come to Washington, D.C. and beg for crumbs and demonstrate my plight as an underpaid anesthesiologist and help educate these congressmen that $78 paid to an anesthesiologist for a knee replacement anesthetic it's so outrageous, and you need to pay me more. And then I realized, well, I'm a special interest, just like everybody else up here. And furthermore, they have no money that they didn't first steal through taxation. And if I take that money, then I'm the recipient of stolen property. And that began to churn in my stomach, and it was gross. And I just couldn't reconcile that. It was just too terribly inconsistent. how can you claim to be a small government conservative or libertarian or whatever, and at the same time beg for more money from government? And I think it was two physicians in particular. It was an internist named Lois Copeland, and it was a neurosurgeon in Washington State named Michael Schlitt. And they opted out of Medicare and were happy to talk about it and tell everyone then what their experience was with Medicare patients after that, how much healthier that relationship was without the Medicare F-16 in the room with them. And that was a big thing for me. That was a nauseating moment that I had to walk away from and do something about, not unlike, I think, what you just described.
Sure. So, I can imagine some of our listeners, whether it's medical students or residents or fellows who are listening now, are wondering, okay, so now we've had two guys tell us about the benefits of Zofran. What led to this? Why this visceral reaction? Why this response, which is so so powerful? And I think to help them understand, it might be useful, since I think a lot of our listeners probably aren't familiar with you and the pioneering work you've done. If you could tell us a little bit about how the Surgery Center of Oklahoma is different than all your competitors, and how it's also inspiring other people in Texas and in other parts of the country to build something similar.
Well, we are different and we're the same because we saw patients encounter financial hardship because they were, in some cases, financially assassinated by the hospitals where we'd previously worked. We felt very strongly that we could not be involved with patients in an exchange that was not mutually beneficial, either from the medical side or from the financial side. And this is a philosophical decision. This is a decision to, in our minds, do the right thing. It's the golden rule. This is an old Christian principle that is, terribly ancient. But mutually beneficial exchange, in the absence of mutually beneficial exchange, is what characterizes the biggest part of the medical industry and why it's all wrong. Mutually beneficial exchange is what characterizes interactions that occur in a free market competitive economy. And that's where we were in the Surgery Center of Oklahoma. And all that we've done here is an extension and manifestation of that. So in 2009, I decided, for a variety of reasons, to put our money where our mouth was. We wave the free market flag, but it's time to tell the world, here is what we do and here is what we charge for it, and let the market judge us. If you're too high, then people don't buy from you. If you're too low, then you can't make a living and there's people lined up around the block taking everything you have. So we felt like it was time to put our money where our mouth was. So in 2009, I posted all of the all-inclusive surgical prices that we had quoted over the phone ever since 1997. I put them all on the website. And the first patients to take advantage of that move, which I knew was radical, but I actually did not know how radical it was. The first patients to take advantage of that were Canadians. Now, they all have coverage and insurance. They have Medicare for all in Canada. So why in the world would a Canadian fly or drive to Oklahoma City to have surgery? And the reason is they have coverage, whatever that means. They just don't have access to the care that so many millions of them require. So they fly or drive to the United States and try to find it. And my online pricing was a finite, quantifiable amount paid, which could end their nightmare. And the most common nightmare that we heard then is the same one we hear now. And that is a a woman requiring a hysterectomy whose bleeding is so severe that they need transfusions now and then. Well, when they're told you can see a gynecologist in 3 years, they know kind of what they're up against. And our price is listed online. I think it's about $8,500 or $9,000, something like that. That pays surgeon, anesthesia, facility, and pathology. It pays everything. So they know they can end their nightmare with that payment. So, Canadians came, uninsured patients from out of the state of Oklahoma came, and then I knew, because we were self-funded for the benefit of our employees here at the Surgery Center of Oklahoma, I knew self-funded employers had the same sticker shock as an individual paying for their care, and I knew it was a matter of time before they showed up. So for you residents and fellows out there, this is the way to think about what self-funding is. Self-funding is when a company, usually, not always, a company that has 50, 60 or more employees, they decide they are going to pay the medical bills of their employees out of operational revenue, out of the revenue that they collect in their business, rather than send a wad of money off to Blue Cross, United, Cigna, Aetna, Humana, and have them assume risk, pay bills, and keep the difference. The other way those companies make money is they deny care. If somebody submits a claim, they say, no, we're not going to pay that. That's the other way. The BUCAH, we call them BUCA. That's the other way they make money, is they just deny care. Well, if you're self-funded, you're in control of what is paid. So self-funded employers can make a very compelling case that they actually care more about their employees than companies that don't self-fund, because the question of denying or not is then in the hands of the employer if they are in charge of the health plan. And an employer that denies care for their health plan runs the risk of, guess what, not having any employees. So the accountability is all built in, and it really is a better, more personal way to deal with health issues should they come up for the benefit of employees. So my friend Marty McCary, who some of you may have heard of, he refers to self-funded buyers, employers, as proxy buyers. And I love that, because it really is the patient's money in a self-funded health plan, but someone has to be the captain of the ship. And if the employer is a good proxy buyer, then they will choose an outfit like Surgery Center of Oklahoma or yours. And that way they can buy a reasonably priced surgery in the highest quality, rather than going down the street to the so-called not-for-profit hospital and paying 10 times that amount at probably worse quality. So this is a manifestation, really, of our philosophy of mutually beneficial exchange and free competitive markets, and not to say, I'm a doctor, I don't get involved in the money stuff. That is a cop-out, and that leaves your patients abandoned to the predators, and there's plenty of them out there. I think increasingly as physicians, we need to educate ourselves on economics and the philosophy of economics, and how do you deal with people? How do you ensure that the ethics and morals that govern your life are consistent, and it also include your business life and how you deal with patients? So there is right and wrong, there's black and white, and abandoning patients to some hospital or insurance carrier is really abandoning them, is same as abandoning them medically, in my opinion.
For sure. I agree 100%. One of the things that really struck me as I was listening to you is, is the fact that as a surgeon and you as an anesthesiologist and just about anybody else in medicine, I mean, we spend so much time. We're taught to spend a lot of time talking to our patients about the risks, benefits, and alternatives of a procedure or a treatment from a medical standpoint. But what's missing from that equation, and what I think is really unfair in a conventional model, is that we weren't taught to talk to patients about the risks, benefits, and alternatives of the treatment from a financial standpoint. And I would argue that that's just as important as the medical risks, because I can't tell you how many patients before I started on the direct care road, I can't tell you how many patients came back to me, months or years later, and they'd say, Doc, thank you so much for taking care of my health problem. It just sucks that now I've got a financial problem.
Yeah. People ask me a lot of times, why are physicians such bad businessmen? And I think part of that answer is that we're not only not educated in medical school or in our training about the business of medicine. We're discouraged from even thinking about it. I mean, that you're even thinking about it must mean you're a greedy capitalist pig. And you're going to select, some subspecialty only because of the money. And that's really unfortunate, because medical students and residents will come out of training with this very misguided trust. I'm going to go to work for this not-for-profit hospital that has a cross on top. And so they must have the best interests of the patients in mind. And then you show up and you realize, wait a minute, there's a lot of doctors on this staff that are just terrible. What in the world? How did they get credentialed here? And then you very cynically, if you're brave enough, come to the conclusion that, bad doctors and all these complications I have make the hospital a lot more money than if everything goes smoothly. And there's no way that could be on their radar. There's no way they could be thinking that. And so a lot of this stuff are just things that are really hard to face, things that are hard to allow yourself to entertain, because once you start thinking that, you can't unthink it. But I think that part of discouraging physicians in training from thinking about the money game is that there's so much to hide that they don't want us thinking about. And God forbid the so-called not-for-profit hospital has a competitor down the street that's charging a tenth of what they do and is providing better care. That's their real nightmare. And I think once, as physicians, we realize we can get through our day, take better care of patients, and not have all of these intermediaries in the waiting room, in the exam room, in the operating room. I think that's a real nightmare for the powers in charge. Keep in mind, not all, but most, the vast majority of hospitals in the United States were all started by physicians, owned and controlled by the physicians. There were a few that were not. There are exceptions to that, but the vast majority were. So this model now of most of the hospitals not owned and controlled by doctors, that is the opposite of how things got started here in the United States. My great uncle was the only physician in a town southwest of Oklahoma City called Chickasha. He was the only physician there for about 30 years, and he owned and controlled the only hospital in town. And Dr. Bays was a hero. He was a guy that rode out on his horse to go deliver babies, and he was a hero to everyone that lived there. And the old timers now call the community hospital that's there, they still call it Bays Hospital because they remember Dr. Bays. So anyhow, we need to make sure we do not abdicate our responsibility to learn about how how does this thing work and how can it be better? How can it be more efficient? How can care be better and simultaneously prices be lower? And that's what consumes Steve Lantier and me and does still every day because we're always trying to do better and charge less for it. And that the absence of that in this industry is why things are so expensive and care and the quality of care is so sporadic.
So what do you say? So I get a lot of pushback, mainly from other physicians, but sometimes I'll hear it from patients when they say, well, it's great that you're doing direct care and you cut out the insurance company. You must have nothing but really, really rich patients, but you don't care about poor people. What do you say to that?
Well, keep in mind, when Surgery Center of Oklahoma first opened in 1997, we were quoting prices over the phone. We were also talking to patients that had insurance, only to discover that our all-inclusive price was less than their in-network deductible. So for you doctors in training who don't know what I'm talking about, if you have a $2,000 deductible, that's what you have to pay before insurance ever steps in and helps out to pay the bill. They also don't pay all of what remains. They pay a percentage of what remains, and you're still stuck with 20% of it, usually, or more. So we were quoting prices all in, surgeon, anesthesia, facility, pathology, that were less than patients' in-network deductibles. So who was the pal of the poor? So people say, well, yeah, what about the poor? And I said, well, the poor are the people who are at my facility who cannot afford, the rates at the hospital. And it is generally 10 to 1. We charge about a tenth of what they do, and we make money. So that's really how greedy the system is. So, yeah, I mean, it's the poor people who are attracted to known reasonable pricing. So if a surgeon calls me and says, I've got a patient, I've got family here, Buster Brown needs his tonsils out, they don't really have anything. Okay, as an anesthesiologist, I ask the surgeon, how much are you going to charge them? Well, I'm not going to charge them at all. I don't think they have anything. Okay, I follow his lead. As an anesthesiologist, I don't charge the patient if the surgeon's not going to. But I run the Surgery Center of Oklahoma, and we have hard costs. I mean, we have to buy things in order to perform surgeries. So I ask, do you think they can cover the cost of supplies? Well, I don't know. How much do you think it's going to cost to do a tonsillectomy? I don't know, about $200. Well, let me ask them. Well, no, they can't. But their uncle, they just called him, and he's across town. He said he'll come up with the $200 and cover the cost of supplies. So now we've performed this surgery at our place. We received reimbursement directly from the family for the cost of supplies. So all we've done is donate our time. And doctors are happy to do that. I don't want to sit down and physically write a check myself on personal funds to cover supplies. Not that we haven't done that from time to time. But if the patients can just cover the supply costs, then we're in the business of donating our time. And we're all charitable. I think that we are naturally charitable. We are called to be charitable to the extent that we can. Now, at the not-for-profit hospital, that patient would be making payments that they probably could not afford for the rest of their life for a very simple operation like that. The cost of the supplies for which is probably in the $200 range. So, what about the poor? Yeah, I mean, the poor obviously, know where they need to go. And many of the poor will go to the big hospitals because they know they're just going to default on the payment anyway. And the hospitals don't care. The hospitals don't care if they don't get paid because there's this kickback game that they play with Washington, D.C., where they are actually paid to the extent that they claim that they weren't paid. So hospitals actually are incentivized to exaggerate their losses First, to get all the red ink they can find to maintain the fiction of their not-for-profit status. Second, because they get a kickback to the extent that they claim that they provided all of this care to the community for which they were not compensated, and then their Medicare payments for the next calendar year are padded to make up for that, for whatever they claim. So, that this whole system is so bad, and it so distorts things, and it incentivizes the hospitals to actually charge more because they maximize their opportunity on that scam. And the only way to fix this is to provide an alternative. I don't think the current system can actually be remedied. I think it's too sick. I don't think this is a swimming pool that has to be drained. The water can't really be treated. This is bad, and it's very political, and the people who benefit from this current system are very, very wealthy and are willing to pay more than anybody who's honest can to combat them. So I think the answer is really what we've done and what we champion, and that's create an alternative for the discerning buyer. And let them have their sandbox, and you go, boy. I mean, and then we just do something different. And then if the buyers decide to patronize the alternative, then we have a great practice. We have a great relationship with patients. Patients pay a fraction of what they normally would. They get better care, and everybody involved in that process just is in a much better spot.
That's awesome. So some of our listeners, as you know, are medical students or residents or fellows. And I imagine a bunch of them are kind of sitting there right now listening to this thinking, okay, this all sounds great. How do I do it? How do I get involved? How do I get plugged into this parallel ecosystem, which on the face of it sounds like a significantly better option than what everybody else is telling me about? What's your advice to those people that are asking themselves that question right now?
There are a lot of ways to step into this world. The most obvious and logical one is to find those who are already in this world and join up with them. So I don't care what specialty you're in, someone out there is in that specialty that at some level is operating in the way that I've described. People say, well, why isn't everyone doing this? Well, everyone is doing this at some level, maybe not very much. I do it. That's all that I do. I mean, all I do is deal with people who buy from me at our website price. I mean, that's all I do. So if you want to go into endocrinology, how do I do that in this free market world? Well, you look at the videos of Free Market Medical Association, and you'll see an endocrinologist there, already from San Antonio, and she does this. She does this for cash, or she does this for patients, and she does not work with insurance, and it's a beautiful practice. You could look at a group that is practicing endocrinology in the traditional way, and they're probably looking for help because there's a real shortage of endocrinologists and neurologists, and I could go on and on in the United States. So all of these private groups are looking for people who finish their training who want to join them. So you could join that practice, and then you could practice in kind of a hybrid way. You say, yeah, okay, I'll help you with, the normal way of doing business, but I also want to offer to patients this other way of interacting with me. And so that's one way to get your feet on the ground. The one thing I'll tell you, you forget everything I've said. Forget everything I've said up to this point. I want you to hear this. If you're a medical student or you're a resident, the one thing you should never, ever do is go to work for a hospital. That's the one thing you should never do. Here's why. It is only a matter of time It is inevitable once you take that job that you will face the dilemma you should never face. And it is the stuff that burnout is made of. It's the stuff that I don't want to do this anymore is made of. And here's the dilemma. Do I do what is best for this patient in front of me, or do I do what my employer wants me to do? Two very different things. You think that's crazy? Patient in front of you needs their gallbladder taken out. You happen to know that the best surgeon to perform a cholecystectomy is across town. It does not work for the same hospital system you do, but you're prohibited from referring to them. You are required to refer to the butcher down the hall, who you know is horrible, whose complications you've already seen. So what do? Do I do what is best for this patient in front of me, or do I do what's necessary to keep my job? You should never, ever, as a physician, be in that situation. And it's inevitable. It happens every day to hospital employees. Are there hospital-employed primary care doctors out there who courageously battle this every single day and always do the right thing? You're damn right there are. And they are exhausted and they're burning out like crazy, because that should not be a struggle that is part of your everyday life. So the only way to avoid that dilemma is for you to be a free agent and not to be a tool. Remember the proverb, whose bread I eat, his song I must sing. He who is paying you makes the rules. So you need to just make sure it's the patient that's paying you. And then the arrangement is so wonderful and it's so uncontaminated and unconflicted. So you don't go work for a hospital. And the way you don't go to work for a hospital, if you're a general surgeon, if you're going to anesthesia, endocrinology, join a group that is in private practice. And even if you practice in the traditional way with insurance companies as the intermediary, you can begin slowly but surely to taper that out of your practice and begin to work with patients paying you directly. So that's how I would recommend that you do this. There are plenty of private practice groups out there that are desperate for help. When you set up your decision grid, what I want to do, where do I want to live, what kind of life do I want to have, how much call do I want to take, you start thinking about all the things that factor into your decision on what field am I going to pursue, and having made that decision, where am I going to live, you want to think seriously about joining a group wherever they are that is in private practice. And that may mean you are not in exactly the city or location where you had hoped to practice, but the trade-off there is it cannot be discounted.
Sure. So we got a bunch of medical students that are listening to this podcast or watching, and they've heard about the Free Market Medical Association and they want to learn more, but they can't afford to get to the meeting. What's your recommendation?
So there's an active effort within the organization to raise funds and promote the attendance of medical students. The Benjamin Rush Institute is probably the place to go to best keep your finger on the pulse of that movement. We have been approached several times by very, very large donors that want to encourage this. None of them have really committed at this point. Jay Kempton and I hope someday to say we've received $1 million grant and we can fund medical students forever. That has not happened. Maybe somebody watching this will hear what I just said. But there is a discounted rate for medical students, and there is a scholarship mechanism, I'll say that, within the organization to receive funds, and people donate to it. I donate to it. People donate to it to ensure that cash-strapped medical students can get to the conference and receive the antidote. Awesome.
Any last words of wisdom you have for everybody, Keith? Anything you want to share with the medical students or the residents, or anything at all?
Don't go work for a hospital. That's the money line. Just don't do it.
Amen.
Don't do it.
Amen. Yeah. Yeah. Well, I couldn't agree with you more. Direct care it's been life-changing for me, life-changing for my patients. And I just, I know you've heard me say this before. I think it bears repeating. I just want to thank you again for your leadership and your pioneering work in this field. You inspired me to build my practice and to do what I do for my patients today, and my patients are better for it. So thank you for that.
Thank you. I'm honored for you to say that. That's wonderful to hear. Thank you.
Thank you for joining us on the Direct Care Movement podcast. We're excited that you joined us, and we're looking forward to having you join us in future episodes as we dive into more questions and more concerns and more solutions in the direct care space, whether it's direct primary care or direct specialty care. If you liked what you heard and you want to know more, please click like and subscribe and leave us a review. And don't be afraid to reach out to us directly so we can get you more information about direct care, whether it's direct primary care or direct specialty care.